Hi everyone, thanks for coming today. Today we're going to be teaching on gastric point of care ultrasound for mitigating aspiration risk in patients on GLP-1 agonists. This is for partial completion of our doctoral project for nurse anesthesia school. This is done by myself, Anna Trimble, also Lauren Sievert, and Sophie Davis with our faculty mentor, Dr. Gordon. If you haven't already, please complete the pre-education survey. You can use the QR code on this page, or you should have been emailed a link and a QR code as well. The objectives for this education are to understand the pharmacology of GLP-1s, ultrasound fundamentals, how to perform gastric point of care ultrasound, otherwise known as gastric POCUS, and the literature recommendations. We want you to recognize the significance of aspiration risk in patients on GLP-1s and apply this knowledge to your practice and the decision pathway flow sheet.
While the incidence of pulmonary aspiration in the general surgical population is generally low, it is a serious complication and has been found to be the most common cause of death related to airway management. There are many factors that can increase the risk for delayed gastric emptying, and one in particular is the use of glucagon-like peptide 1 receptor agonists, or GLP-1s. Patients on these drugs have been found to be more likely to have retained solid gastric contents noted upon endoscopy. This becomes problematic with the rise of GLP-1s in the recent years. This can be attributed to heavy social media influence along with increased availability of getting these medications, such as from online providers or from med spas. While they're very effective for weight loss and treatment of type 2 diabetes, there is a higher likelihood that these patients will have full stomachs despite following standard fasting guidelines. With the rise in GLP-1s, it becomes critical to emphasize safety when developing an anesthetic plan that puts patients at risk for aspiration. A close claims project from years 2000 to 2014 by the American Society of Anesthesiologists found that the aspiration of gastric contents was linked to 5% of claims during the study. Pulmonary aspiration resulted in death in 66 of the 115 claims. Severe injury resulted in 14% of the claims. Also of concern was the anesthetic management was deemed substandard in 59% of the claims. It's important to note that the volume, acidity, and type of aspirate are factors that determine patient outcomes should aspiration of stomach contents occur. Preventing aspiration does depend on recommended fasting intervals. However, factors that cause delayed gastric emptying and retention of gastric contents become problematic. Gastric point of care ultrasound is non-invasive, fast, and portable, and provides a valuable assessment of gastric contents in prevention of aspiration. This can be used to evaluate gastric contents when NPO status is unknown or the provider is uncertain of gastric volume. Gastric ultrasound is easy to learn and perform, and ultimately, findings from ultrasound help guide a safer anesthetic plan for the patient.
All right, so a little bit of an introduction to the GLP-1 medications. These medications are obviously a very popular category of meds these days. They're definitely not new to the market, but their effects and newfound popularity make them an important class of drugs to keep an eye on for anesthesia providers who come across them on their patients' charts. So, according to the American Society of Anesthesiologists, as of 2024, about 1 in 8 US adults were using a GLP-1 medication for diabetes treatment or for weight loss. Just a little fun fact, the first GLP-1 drug was approved by the FDA in the early 2000s for treatment of type 2 diabetes. So GLP-1 medications work to lower serum glucose after a meal and improve metabolism. GLP-1 is a naturally occurring hormone that's released by the body after oral intake of things like fats or carbs. And these drugs increase glucose-dependent insulin synthesis and secretion of insulin from beta cells in the pancreas. Glucagon secretion is also suppressed, as well as appetite. GLP-1 drugs are said to have cardioprotective effects. They help to lower blood pressure, which can reduce the risk of future events like a stroke. And they help to prevent coronary atherosclerosis from forming or progressing, which can theoretically prevent future acute cardiac events. There's also another peptide called glucose-dependent insulinotropic polypeptide, also known as GIP. GLP-1 and GIP are naturally occurring hormones in the body. They have many similarities, but also are very different. So they both, like I said, decrease alpha cell glucagon production and slow gastric emptying. Other effects of the GLP-1 drugs are neuroprotection and increased satiety, which is feeling full. So here's a little graphic that shows the metabolic effects of the GLP-1 drugs. You can see by the heart graphic, they show increased cardioprotection, decreased blood pressure. By the brain, you see neuroprotection. By the liver, you see decreased gluconeogenesis. And you can take a look to find out all the metabolic effects of the GLP-1 drugs. So as far as adverse effects, there's a list on the right here. The most common issues we hear about with these drugs are not surprisingly GI related, with some adverse effects including nausea, vomiting, diarrhea or constipation, and then abdominal pain. The current literature suggests that the most severe side effects usually occur when the medication is either first being started or the dose is being up-titrated. Generally, when GLP-1 medications are used alone, the risk for hypoglycemic events is very rare, but if they're used with something like an oral anti-diabetic drug or insulin, hypoglycemia is also definitely a risk. You can see here negative effects on the thyroid is listed as an adverse effects. As far as concerns about the effects on the thyroid, there have been some animal studies that suggest certain GLP-1s can cause thyroid cancer. The actual risk in humans is likely low, but patients with a personal or family history of thyroid cancer may not be appropriate to take these drugs or may be more closely followed by their provider. Other less common side effects include gallbladder or biliary issues, pancreatitis, and then, of course, injection site irritation from subcutaneous injection. So the currently available GLP-1s, according to the American Diabetes Association, these GLP-1 receptor agonists are currently on the market and they're FDA approved to treat type 2 diabetes. So we've got dulaglutide, also known as Trulicity, that is a weekly injection. Exenatide, also known as Byetta, that is a twice daily injection. The exenatide extended release, also known as Bydureon, that is a weekly injection. Liraglutide, also known as Victoza, is a daily injection. I'm going to butcher this name, but lixisenatide, also known as Adlixin, is a daily injection. And then we have injectable semaglutide, also known as Ozempic, which is a weekly injection. There's also an oral formulation of semaglutide called Rybelsus, which is taken orally and daily. And then tirzepatide, other known as Mounjaro, is the only currently available combined GLP-1/GIP receptor agonist. The FDA has also approved certain formulations of the GLP-1 drugs for weight loss. So specifically, the form of semaglutide known as Wegovy is a weekly injection. The form of liraglutide known as Saxenda is a daily injection. And then the form of tirzepatide known as Zepbound is a weekly injection. And those three are the ones that are FDA approved for weight loss specifically. So GLP-1s and anesthesia. GLP-1 agonists are known to cause delayed gastric emptying. This poses a risk for regurgitation and aspiration of gastric contents during anesthesia. The American Society of Anesthesiologists recommendations have evolved and changed over recent years. In June of 2023, the ASA guidelines were to hold daily medications 1 day before and weekly medications 1 week before an elective surgery or procedure. There was not enough evidence to support changing the preoperative fasting guidelines in these patients specifically, so that didn't happen. They were instructed to follow current ASA fasting guidelines, but just change the dosing of their drugs. And then as of October in 2024, the ASA suggested that patients on GLP-1s could continue these drugs before surgery with a risk versus benefit assessment being made regarding discontinuing or continuing the medications. So if they were at high risk for GI side effects, they could be put on a 24-hour liquid diet before surgery. And it was suggested that a collaborative effort should be made to assess individual risks and make decisions to avoid adverse events, whether that be using full stomach precautions when planning intubation and initiating anesthesia, or delaying the procedure, canceling the procedure, or rescheduling. Whether that means to continue their medications or to stop their medications. It was just suggested that the clinicians all work together to make an effort to decide what is the best for the patient moving forward. So they suggest to follow current ASA fasting guidelines. The recommendations by the ASA for clear liquids are that clear liquids can be ingested for up to 2 hours before procedures. Breast milk can be ingested for up to 4 hours before procedures. Infant formula for up to 6 hours before procedures. A light meal or non-human milk may be ingested for up to 6 hours before procedures. And then additional fasting time, which includes 8 or more hours, may be needed in the case of patients who consume fried foods or fatty foods or meat-heavy meals before procedures. And these are all for elective procedures, nothing emergent, obviously.
So now we'll talk about the fundamentals of ultrasound. Ultrasound can be defined as a type of non-ionizing radiation and form of imaging where the provider is able to view a specific tissue in real time. Sound energy moves as a mechanical wave through the tissue or liquids of the body, and an image is made through the exchange of sound and electrical energy. Components of the ultrasound probe, called piezoelectric crystals, are responsible for this exchange between electrical and sound energy, which can also be referred to as the piezoelectric effect. Use of ultrasound also takes into consideration the concept of acoustic impedance, or the degree in which a sound wave travels through a given medium, such as muscle or blood. Once the sound wave encounters a tissue with a different density, the sound wave will reflect. The chart on the lower right-hand corner of the screen shows differing impedance values for different tissues and components of the body. For example, air has a significantly different value as compared to bone. Looking into more of the steps about how ultrasound works, the transducer sends ultrasound waves into the body at a fixed rate and then listens for echoes between pulses. This is the reason behind the rapid refresh on the screen and how images have the ability to move dynamically. First, an electric current is applied to piezoelectric elements, which causes vibration in the transducer. The vibration of the elements sends ultrasound waves into the body. The wave encounters a boundary between two different tissue types. This is where we recall the concept of acoustic impedance and the reflection of the waves. These waves echo off the tissue and the wave returns to the transducer. Upon returning to the transducer, the piezoelectric elements vibrate and mechanical energy converts to electrical energy. The information transfer back to the transducer undergoes an algorithm that plots a dot on the ultrasound screen, which then combines the total sound energy and intensity of the returning echoes. This results in a 2D image in B mode on the screen. Now we'll look at the different types of transducers used for point-of-care ultrasound. The first type of ultrasound transducer is a linear array, which operates at a higher frequency range of 5 to 15 megahertz. In this type of transducer, the piezoelectric crystals are arranged in parallel. This is the transducer of choice for superficial structures such as arteries, veins, soft tissue, trachea, and the thyroid. The next type of or the next type of transducer is the curvy linear array, which has lower frequency range between 2 to 5 megahertz. This transducer has piezoelectric crystals in a convex arrangement and has a fan-like image, which is narrow at the top and becomes wider as the ultrasound signal progresses into deeper tissue. This transducer is meant for deeper anatomy, such as the abdomen, bladder, bowel, and renal assessments. The third transducer is a phased array, which is intended for deep structure viewing, such as heart and intercostal spaces. This transducer is narrow in the near field and fans as depth increases. Its frequency range is 1 to 5 megahertz. Now we'll look at the butterfly ultrasound transducer, and this is the point of care ultrasound, what point of care ultrasound at Minji uses and differs somewhat from traditional point of care ultrasound systems because the butterfly uses an all-in-one transducer that combines the linear, phased, and curvilinear array technology within one probe. This probe can be used for the entire body and has a frequency range of 1 to 12 megahertz. This probe differs from standard probes by not containing piezoelectric crystals. Instead, the probe has an ultrasound on-chip technology through a capacitive micro-machined ultrasonic transducer, where the elements are in a chip roughly the size of a postage stamp. And as you can see in the picture on the lower right-hand corner, the difference, how it does combine all in one handheld. Now we'll look at different transducer motions and positioning. So the first picture shows a sliding motion, which maintains the same angle of incidence by moving the short axis of the transducer. The next shows a rocking motion, which gives a better contact between the transducer and the patient. This moves the transducer from side to side and maintains the long axis of the transducer. Rotating motion in clockwise or counterclockwise directions are used when transitioning from short to long axis imaging and vice versa. The compressing motion can improve image resolution through reduction in distance between the transducer and target anatomy. The tilting motion changes the angle of incidence and assists with orienting the ultrasound beam perpendicular to the anatomical structure, which can improve the quality of the image. Now we'll look at positioning of the ultrasound transducer, and best position would be to hold the transducer near the base between your fingers and thumb, almost like holding a pencil. Don't hold the transducer at the cable. You'll want to anchor your wrist and forearm to give a good support base. This will give optimal fine motor control and allow for the best precision. Now we'll look at transducer position and orientation. It's important to orient the transducer correctly when using to obtain the most accurate image on the screen. To do this, make note of where the orientation marker is on the transducer. When viewing the long axis or longitudinal view, make sure to point the orientation marker towards the patient's head. For short axis or a cross-sectional view, make sure to point the orientation marker toward the patient's right side. You will also see the corresponding dot on the screen that indicates the correct alignment between position and orientation marker of the transducer. Another important concept when using ultrasound is the gain feature. This adjusts the brightness of the image. Too much gain will make the screen too bright, while too little gain makes the screen too dark. While this feature enhances or reduces brightness, it will not alter the contrast of the anatomy on the screen. And as you can see the illustrations at the very bottom, too much gain is too white, and then too little gain is way too dark. Now we'll look into some of the differences between what you will be seeing on the screen. So the amplitude of the returning ultrasound signal determines the brightness of each dot on the ultrasound screen and also determines the ability of the tissue to transmit or reflect sound waves depending on the surrounding tissues. This process describes the concept of echogenicity. So as you can see, there's hyperechoic, which will be more white, hypoechoic, which is a gray, and then anechoic is black. Going further into that, for hyperechoic, this will appear bright white. Where strong echoes are produced, echoes are at high amplitude and tissues have a high level of impedance. Examples of this could be for bone and fascial lines. Next, we have hypoechoic, darker gray, which is weak and low amplitude echoes for low impedance tissues such as solid organs, skin, cartilage, and adipose tissue. Lastly, we have anechoic, which is black, which also refers to linking no echo produced. Examples of this would be fluid, cysts, vasculature, and ascites. Now we can apply this concept of ultrasound to gastric assessment, looking at the rectus abdominis muscle. You can see where number 1 is labeled, that's the serosa, which is hyperechoic. 2 being muscularis propriae, hypoechoic, the dark gray. Submucosa, hyperechoic. Muscularis mucosae, hypoechoic, and then finally the mucosal air interface, which is hyperechoic. Now we'll briefly talk about some of the basic ultrasound terms and what is referred to as knobology. On a traditional ultrasound machine, this will not be what it looks like on a butterfly ultrasound because butterfly ultrasound will not have this keyboard. But for the sake of just learning traditional ultrasound, we'll look at depth, focus, mode, and Doppler. Depth is referred to or can be described for the anatomical target should be in the middle of the screen and the best transducer intended for the best resolution for the part of the body you're looking at. Focus refers to, so target anatomy should be in the focal zone. The beam width will be the most narrow and thin in the focal zone. For mode, a B mode will give a real-time image and is used in most bedside ultrasound procedures. The B refers to the brightness of the on-screen pixels. And M mode refers to motion and is a time-lapse image that shows structural movement over time. Now we'll look at some of the features that are offered for butterfly ultrasound. So the butterfly ultrasound system, of course, will be a touchscreen that can be accessed on an iPad or on a smartphone that's connected to the transducer. So butterfly ultrasound is both similar and different when compared to other traditional versions of bedside ultrasound because of its portability. A key difference is that butterfly ultrasound lacks the keyboard or the panel with the knobs and buttons, like the device just recently shown. The butterfly has similar features. However, these are changed on the touchscreen. As you can see, you're able to first select in the bottom left the preset anatomy that you will be assessing. In our case, we would select the presets and scroll to abdomen. Another feature right next to the presets is the freeze button, which allows you to freeze the screen and calculate gastric volume. There are other options to record and also to switch from B mode to M mode. On the left side, the depth can be changed by touching the screen and pinching the screen up and down to increase and decrease. And at the top of the screen, gain can be changed by touching the screen and moving in and outward.
Now let's learn how to perform a gastric point of care ultrasound. Point of care ultrasound is an essential bedside diagnostic skill for anesthesia providers. It is safe, effective, inexpensive, and improves patient outcomes. Gastric ultrasound provides an objective assessment of gastric contents and aspiration risk, especially when subjective evaluation is inconclusive. With proper training, you can perform the scan in under 5 minutes. Some considerations include that gastric POCUS is not reliable in patients with abnormal gastric anatomy. For example, patients with a hiatal hernia or who have had gastric banding, previous gastric bypass, gastric sleeve, or fundoplication surgeries. Also, the patient must be capable of laying in the right lateral decubitus position for this exam. For today's education, we are focusing on adults only and will not be covering the pediatric or parturient populations. First, position the patient supine. Scanning in this position first is helpful because if solid or thick fluid is observed, the stomach can be considered full and the exam is complete. Remember, though, that you can never call an empty stomach based on the supine position alone. If you see what you suspect is an empty stomach or want to quantify liquid contents, proceed to scanning in the right lateral decubitus position with the patient's head slightly up at less than 45 degrees. Why right lateral decubitus? Because in this position, additional gastric contents will fall into the antrum by gravity. This position is the most sensitive for determining if the stomach is truly empty and for measuring volume. Apply ultrasound gel and place the probe just under the xiphoid process with the orientation marker pointed toward the patient's head. Generally, the probe should be positioned just right of midline and tilted towards the patient's head, but due to differing anatomy, you may need to slide and tilt the probe in different directions until you find identifiable structures. With the ultrasound transducer placed like this, our cross-sectional image will be parallel to the sagittal plane of the body. This is also known as the parasagittal approach. Here are the key anatomical landmarks you should be looking for. The liver is the large hypoechoic structure on the left. Just to the right of the liver is the gastric antrum. The antrum is a hollow viscus with a characteristic 5-layer wall that Lauren explained to you previously. It is relatively superficial, only about 3 to 4 centimeters deep, and this is what we use to assess gastric contents. It accurately reflects the contents of the entire stomach. The aorta is the anechoic pulsatile line at the bottom of the screen, and you may be able to see the hyperechoic spine just below it. The superior mesenteric artery and the pancreas may be seen on the right side of the screen, but they're not always visible and are not necessary for a good assessment. If you see any other hollow organs, it could be the duodenum or colon, but just remember that the gastric antrum is easily identifiable based on its location right next to the liver. Quickly going left to right with the photos on this slide, the first picture is a good representation of the parasagittal view and anatomy. Next, we see the antrum relative to the rest of the stomach. And lastly, we see a gastric ultrasound with the landmarks labeled 1, liver, 2, gastric antrum, 3, superior mesenteric artery, and 4, aorta. There are 4 characteristic patterns that we look for in a qualitative assessment, ranging from an empty to a full antrum. An empty gastric antrum appears flat and collapsed with thick wall layers. Based on its appearance, an empty antrum is often referred to as a bullseye or a target. It may have a small ring of hypoechoic fluid in the center, representing baseline gastric secretions. If stomach contents appear empty, or if the stomach appears empty in the supine position, scan again in the right lateral decubitus to verify. If it's empty in both positions, then it's a grade 0 antrum. Next, let's look at the clear liquid patterns. The antrum is round, distended with thin walls, and full of dark, homogeneous liquid. As you can see in the top picture, shortly after ingestion of clear liquids or carbonated drinks, you can see little bubbles floating around, which is why its appearance can be described as a starry night. The antrum contents can also be anechoic, as we see in the bottom picture. Clear liquids are assessed as either grade 1 or grade 2, depending on the volume measurement. Let's look at the last antrum pattern, a full stomach. A stomach is considered full if it contains solid contents, thick liquids, or liquids containing milk. The antrum is distended. Shortly after ingesting solids, the stomach will contain air that causes artifact on the ultrasound image. So in the early stage, you may only see the anterior wall of the gastric antrum with a shadow cast below it that obscures other landmarks. This is commonly referred to as frosted glass. We see an example of this in the top image. Late stage solids, approximately 2 hours after ingestion, are partially digested and have more of a homogeneous appearance. You may see solid chunks or a mixture of liquids and solids. If you see a full stomach in the supine position, you do not need to get the patient in the right lateral decubitus position. Your assessment is complete. To do a quantitative assessment of clear liquids and determine if the antrum is grade 1 or grade 2, you can use the gastric volume calculator that's available on the Butterfly Ultrasound app. If you do ever use a traditional ultrasound machine, you would need to use the trace feature and then compare the cross-sectional area to a predictive model. But for today, I'm going to focus on how to do it specifically using the Butterfly Ultrasound. First, select abdomen or deep abdomen on the scan screen. Then, under the Calculations heading, select Gastric Volume. Freeze the image, then select the Measurement button and use the calipers to measure the mean anteroposterior diameter and the mean craniocaudal diameter of the antrum and add the patient's age. You can see an example of the caliper placement in the image on this slide. Make sure to include the entire thickness of the antrum walls. Click Confirm, then an estimated volume will appear at the bottom of the screen. If you're curious about the math, I included the equation here, but luckily the Butterfly does it for us. If the given volume is less than 1.5 milliliters per kilogram, the antrum is grade 1. If it's greater than 1.5 milliliters per kilogram, then it's grade 2. I've mentioned the grading briefly in other slides. This 3-point grading system was proposed by Dr. Perlas and is validated for risk assessment in the clinical setting. We can see that grade 0 or an empty antrum has a low aspiration risk. A grade 1 antrum, which has visible clear fluid in the right lateral decubitus position, or less than 1.5 mils per kg volume noted on the quantitative assessment, is also a low aspiration risk. When clear liquid is visible in both supine and right lateral decubitus positioning, or the quantitative assessment shows greater than 1.5 mils per kg, it is interpreted as a grade 2 antrum and a high aspiration risk. This is a flow chart, essentially showing the same guidance as the previous grading system, just in a different way. We can see that, for example, if your patient has a grade 1 antrum, you can safely proceed with the case. If your patient has a grade 2 antrum, you should consider the urgency of the procedure and possibly add aspiration prophylaxis and an RSI to the anesthetic plan.
All right, so after our education, we're just gonna go through a little demonstration of the equipment that we know you guys have. So we'll show you the butterfly and then how to get a good view on gastric POCUS for your patient and what positioning to do and everything. So really, all you need are your butterfly ultrasound probe with your little plug in here, and then your iPad with the Butterfly IQ app. So you'll open the app. It'll prompt you to connect the probe, so we'll do that. Okay, so we got our probe connected. There's a lot of different cool features that you can use right on the app here. So one of the first things we'll do, since we're doing gastric ultrasound today, is change the preset, make sure we have that correct, and we're looking at the abdomen today, so we've got it on abdomen. Obviously, if you're doing something else, you can change it, but we're gonna keep it on abdomen. This is your freeze button if you want to freeze an image and draw over the top of it using calipers to measure anything, which we'll show later. Actions button here. You can add labels to your image. You can add Doppler. You can change the mode from M mode to B mode back and forth. There's different, we're gonna use this gastric volume button later. There's different videos for demonstration. And all of this is included in the Pro membership, which you guys have. So the other thing that we'll go over real quick is you can adjust the depth and the gain to get yourself the best image. So to adjust the depth, you'll just drag your finger up and down, and to adjust the gain, you can go left and right. So looking at the probe here, you see the blue dot, and we're gonna wanna measure in the longitudinal direction today. So the blue dot needs to be towards the patient's head, like this. And then you can see here, we're on B mode right now. And the direction that the B is on, whether it's on this side or this side, confirms your directionality of the ultrasound. So if we click it, you can kind of see the image shifted and your directionality will be this way, but we want it over here. So we want our blue dot and our mode button to align. So you can measure your patient in the supine position. Ultimately though, if you have questions or your view, you're not really sure what you're looking at, to get your best estimate, you're gonna want your patient in the right lateral decubitus position. So we'll have you go in the right lateral decubitus position. Okay. So landmarks on the external body for gastric POCUS is you're gonna wanna find the xiphoid process here. So we're gonna go ahead and get ourselves down, put some gel on the probe. And we're probably gonna have to adjust some things so we get a good image here. And you're gonna wanna find the xiphoid process, get your probe on the patient. And there's a couple landmarks that you can look for. So right here, you can see the aorta pulsing. Here's the liver. We're gonna move down a little bit. And depending on what you need to do to get your view, you can either slide the ultrasound probe back and forth, you can rock to get a better view. But we're gonna see if we can find the gastric antrum here. Okay, so you can see, we see stomach contents floating around. I just want to make sure we get everything in view here. So this is our stomach here with all her contents swirling around. And this patient obviously has a fuller stomach. She had some solids and some liquids recently, so depending on, and as she's, breathing, your image changes because of pressure. So we can actually use the gastric volume button on the actions to calculate, and it's not going to be totally precise on this image just because, she's moving, she very recently ate, but we're going to at least show you guys the buttons and the features to be able to hopefully use this tool for yourself. Butterfly Ultrasound also has a website with great step-by-step instructions on how to calculate the gastric volume, what measurements you'll need, how to freeze and save the image. So we'll make sure you guys have access to that. But let's say we have a complete view, and when you do freeze an image, you're going to want the full picture. Let's see, there we go. So you're gonna wanna see all of the stomach wall, and obviously right here we don't necessarily see all of it, but I'm trying to get it in view enough so that we can at least try to be accurate here. So let's say we have the entirety of the stomach wall in view. We're gonna go to, first we're gonna freeze. And we'll wait, there we go. Okay, so let's say that we have our stomach wall right here. We froze our image, so we're gonna go to actions, and we're gonna do a couple measurements. So we're gonna hit gastric volume, go back to actions, and it's gonna ask you for a couple different measurements. So you're gonna want the mean anteroposterior diameter, which is the MAD, and that measures from the front to the back of the stomach. Your MCD here is the mean craniocaudal diameter, and that's, more of the top to bottom. So we'll do the MAD first, which that is going to be, so let's say this and this are the edges of our diameter here. So we've got a measurement here, 5.71 centimeters. We're gonna hit confirm. So that captures that. We're gonna go back to actions. Now we're gonna do the MCD, and this one, we're gonna go the top edge to the bottom edge as best we can here, 1.34 centimeters, so we're gonna confirm that. And then the last thing we have to do going back to actions is put in the patient age. So let's say our patient is 26, we'll hit select, confirm, and you get a volume of 78 mils. So as of right now, you've got all your measurements, you've got your volume. Obviously you can see visually that your patient has a full stomach, so you can decide what is going to be your best anesthetic step to keep the patient safe, whether it's full stomach precautions, whether it's waiting a few hours, whether it's canceling or delaying the procedure. So as you can see, this is a really easy tool that you have at your fingertips. You only need a few supplies. It only takes a few minutes. And if you have questions again about the procedure, what to do first, the features that your ultrasound has, the Butterfly website has a great step-by-step tutorial of how to perform the gastric ultrasound and get an accurate gastric volume on your patient.
You can see, for example, in that video that even with explaining how to perform the gastric ultrasound, it only took us about 7 minutes. So you can imagine that if you were proficient in that scan, that it could be a pretty quick assessment tool. And I just wanted to point out that for the grading system, let's say, for example, I had clear liquids in my stomach for the video. And for easy math, let's say that I'm 50 kilograms. The noted gastric volume was 78 milliliters, which is greater than 1.5 mils per kg, and therefore a grade 2 antrim if it was clear liquid content.
All right, thank you, Anna, for explaining that. We'll head into the multi-societal and literature recommendations. The literature recommendations comes from the literature review that we used to do our research for this project. We ended up finding a total of 16 articles that we used to just peruse the research and formulate results and develop this education. So, patients taking GLP-1 RAs are more likely to have increased residual gastric contents, including solid food particles, even when adhering to current ASA fasting guidelines. So ultimately, the consensus was that clinicians should make a collaborative effort to evaluate risk factors such as the timing and dosage of the GLP-1 receptor agonists, the patient's existing medical conditions, and their current symptoms. So for example, considering the timing and dosage of GLP-1 receptor agonists, we know that patients are the most sensitive and likely to have GI upset during the initial starting of the medication, as well as up titrating doses. If a patient has an existing medical condition, such as a chronic condition, if they've had gastric surgery, like Anna mentioned before, and then current symptoms. So you would want to ask your patients, are you having nausea? Are you having vomiting? Are you having stomach contents like acid reflux come up and things like that? The literature and these different societies also acknowledge that preoperative gastric POCUS could be considered in patients taking the GLP-1s to evaluate aspiration risk. They're very careful to avoid definitive language such as gastric POCUS should be used or should always be used. They're just saying that it could be a tool that you could use. So to minimize the risk of aspiration associated with delayed gastric emptying, strategies may include dietary modifications such as the 24-hour clear liquid diet that we talked about earlier, the use of preoperative gastric point of care ultrasound, also known as gastric POCUS, which we should all know how to do by now, and or adjustments to the anesthetic plan, including following full stomach precautions as far as doing like a rapid sequence intubation and choosing different drugs, canceling the procedure, or postponing it a few hours if needed. So continuing on with the recommendations, The literature suggests that anesthesia providers should know how to correctly perform and interpret gastric ultrasound if they're going to use the results to make changes in the anesthetic care plan. They should use caution in making decisions, as no anesthetic plan is benign and risk versus benefits must always be considered. So, for example, like any tool, basically they're saying you should know how to use it if you're going to use the tool to make decisions regarding patient care. Risk versus benefits, considering either pausing the drug and what that could do for a patient's glucose levels if they're type 2 diabetic, or continuing the drug. And that could possibly be increasing their risk for aspiration because of increased residual gastric content. So always considering the risk versus benefits of deciding to go either path. The literature was definitive in saying that there's a need for ongoing research to better understand the implications of GLP-1s on gastric emptying and perioperative management. They also suggest that further longitudinal studies are important for the assessment of the risk of aspiration of gastric contents in patients taking these drugs. And this is especially important since the use of these drugs and the easier access is continuing to be on the rise. So like we said, there were multiple societies that contributed to these recommendations, and we decided to give a little look into the AANA recommendations specifically. So the AANA released guidelines on the anesthesia care of the patient on a GLP-1 receptor agonist. So they mention considering gastric point of care ultrasound to objectively assess gastric contents and aspiration risks at the bedside, which can be used when gastric contents are uncertain based on subjective assessments alone. So as you can see here, you can kind of follow this chart. It's not quite a flow chart, but it does a good job of helping with decision making. So the first thing would be to assess the presence of GI symptoms such as nausea or vomiting. The second would be withholding medications according to suggested recommendations, and then other considerations. So feel free to look over this chart. We can look at the bottom one, for example. So if you have a patient who is positive for GI symptoms, you can ask yourself, is it suggested that the medication be withheld according to the suggested recommendations? If the answer is no, and they're continuing with the medication, you could perform gastric POCUS to further guide decision making, such as to delay or proceed as a full stomach. We have a couple reference slides here that I'll click through real quick. I'll just give a little disclaimer that the Butterfly Ultrasound website and the AANA website are both great resources if you have further questions about either how to perform gastric POCUS or what the AANA says about gastric POCUS in the anesthesia care of the patient on a GLP-1 receptor agonist. Thank you so much for being here and listening to our education today. We have our post-education survey QR code, and we'd greatly appreciate it if you would take the time to fill that out. Lauren, Anna, and I will be on Zoom for the next few minutes if anybody has further questions about our presentation. So we'll leave this slide up. If you participated in the education and took the pre-survey, this is the QR code for the post-survey. If you could please fill that out so we have all our data, we would really appreciate it. The completion time is about 5 minutes. And on behalf of our group and St. Mary's University, we just want to thank you for your support. Enjoy your day.